Good afternoon, everyone. My name is Jackie Kilmer, and I'm the CEO at Harlem United Community Aid Center. For those of you who don't know who we are a community health, housing, and human services organization serving over 13,000 individuals, the most vulnerable in our city every year. And I'd like to thank you for joining us this afternoon in this session where we'll be learning about housing's role in the state plan to end the AIDS epidemic by 2020. As many of you know, in June of 2014, Governor Cuomo announced a very bold plan to end AIDS in New York State by 2020. There are three components to this plan. First is finding and diagnosing New Yorkers who are HIV positive, ensuring access to care and treatment for those who are HIV positive, and facilitating access to biomedical interventions, including pre- and post-exposure prophylaxis, to reduce the risk of transmission and ultimately curb the epidemic. The governor and the State Department of Health appointed a task force comprised of 63 activists, health service providers, researchers, and public health professionals from around the state who met regularly for 3 months to craft an incredibly comprehensive recommendation plan to end AIDS in New York State by 2020. The resulting blueprint articulates 30 recommendations that must be implemented in order for the plan to be successful. And in this case, successful means that new infections are reduced to fewer than 750 by 2020. But the task force didn't stop there. They went one step further and included 7 recommendations for actually getting to 0 new HIV infections. The governor endorsed the full blueprint at a very energetic and well-attended community event on April 29th, and delivering his speech to hundreds of activists and providers, he said, "We will not stop until AIDS is a thing of the past." While the governor's 3-pronged framework for the plan did not specifically address housing or include housing, we all know that the best prevention and care efforts are really useless for people who lack access to safe, secure place to live. We know that housing has a powerful impact both on HIV incidence as well as on the health of those people who are living with HIV. Homelessness magnifies both the risk of infection, and tenuous housing amplifies health disparities. So here with me today to provide an insider's glimpse on the task force process, the viability of ending AIDS in New York State by 2020, and the role that housing can actually play in that plan are Dan O'Connell, Dan Tietz, and Charles King. Dan O'Connell is the director of the New York State Department of Health AIDS Institute. Dan recently celebrated his 30-year anniversary in state service. During his years of, yes, we should applaud that.
Staying power.
Staying power. During his years of service, he has consistently led efforts to revise and revitalize programming and state laws for HIV, STD, HCV, LGBT health, and drug user health. Over the last 2 years, he worked with community stakeholders on the process that resulted in the blueprint. Mr. O'Connell is an executive committee member of the National Alliance of State and Territorial AIDS Directors, chairs the New York State Interagency Task Force on AIDS, and in 2014 received an award from the White House for his work in hepatitis. So Mr. O'Connell will actually be providing us with an overview of the process and the final blueprint to end AIDS. Dan Tietz was named in May 2014 as the Chief Special Services Officer of New York City's Human Resources Administration. Mr. Tietz oversees programs that focus on the most vulnerable New Yorkers, including the HIV/AIDS Service Administration, or HACA, customized assistance services, adult protective services, emergency and intervention services, including domestic violence shelters and services, home care, and crisis and disaster management. With a $9.7 billion budget and 14,000 employees, HRA assists 3.5 million New Yorkers each year with an extensive range of programs, including food and income support, such as cash assistance, rental assistance, food stamps, Medicaid, and child support. Prior to joining HRA, Mr. Tietz served as the executive director of ACREA, which is a national HIV research, education, and advocacy organization based in New York City. Registered nurse and lawyer, Mr. Tietz has long advocated on behalf of LGBTQI rights and social justice concerns. And from his expert vantage point, Mr. Tietz will be helping us to understand the role that housing will play in the plan to end AIDS. And last, but certainly not least, Charles King. Charles is one of the founders and the president CEO of Housing Works, a community-based not-for-profit organization that provides a full range of services, including housing, healthcare, mental health, chemical dependency services, legal services, advocacy, and job training and employment for homeless men, women, and children living with HIV and other chronic conditions. Charles also serves on the governing body of AIDS as the member of the NGO delegation to the PCB. He can tell us what those letters stand for because I don't know, and served as the co-chair of the task force. Charles holds both a law degree and a Master of Divinity from Yale University, and he's an ordained Baptist minister. To say that Charles has championed the effort to end AIDS in New York State does not do his work justice by any means. He's been a true force to make this plan a reality. Charles will talk to us today about what's next now that the blueprint has been endorsed, the advocacy, implementation, and beyond. So first we'll start with Mr. O'Connell and his presentation, and then Mr. Tietz and Mr. King. We're going to try to hold our questions to the end, and we'll try to leave enough time at the end, certainly, to answer all of your questions. Thanks.
Great.
Yeah.
See if this is going to work. So good afternoon, everyone. It's great to be here. Yay, super.
So far.
Yeah, so an end to AIDS, really, so let's talk about that. So Jackie's already given you kind of the background about what the plan, the three-point plan that the governor announced back last June. And this picture is from Gay Pride, where the announcement was made last year to get us from 3,000 to 750. Obviously, that's not the end of AIDS, but what we believe it is the end of AIDS as an epidemic. We think if we get to this point, what we would see is the first ever decrease in prevalence, number of people living with HIV in New York State, which is a huge milestone towards the real end of the epidemic. But this is hugely exciting for all of us, and we were certainly quite thrilled when the governor made the announcement last year. The first 2 points in terms of finding all the people who remain undiagnosed and getting them into care, and then getting all those people on treatment and towards viral suppression really makes a lot of sense. I don't think anyone argued with that or thought that that was necessarily tremendously groundbreaking, but the third point in terms of PrEP really is, we've come a long way with the epidemic. When I've been doing work with the AIDS Institute for 28 of those 30 years, so a really long time, and back in 1992-93, we used to be diagnosing about 15,000 people a year. So the idea that, we're going to get from 3,000 to 750, people can argue that point, but we've already come from 15,000 to 3,000. So the momentum is there, the skill set's there, the know-how's there, the community relationships there. Lots of things are in place, but we need something that's a real game changer. And we really think that PrEP is that, because the one part of the epidemic that we have had not great success with is among gay men and men who have sex with men. And we really think that PrEP is a game changer because it gives us a harm reduction approach to offer something other than willpower and encouragement and condoms and things like that, which are great for a lot of people, but not so great for others. So this is in 3 sections, a little bit of background on the plan. The first one's really important. Now, you might recognize this guy here. That's Charles getting arrested with this guy here, who's Mark Harrington. Their mouths are open really wide, so they're saying something. Now, it's not rare to have a picture of Charles King getting arrested. But,
with his mouth.
But what's specifically important about this particular picture of Charles King getting arrested is that he and Mark wound up in a jail cell and had some time to talk. And a lot of really great ideas start from people talking in jail cells. And this one really was the beginning of the conversation about, can New York State be the first state in the country to make this bold proclamation that we would end the epidemic And so they came forward with that idea and talked to community folks for a good long time about it, invited the state and the city health departments, and that's Dimitri Daskalakis over on the far, on your right, and has been a huge partner in this. We really need everyone at the table in a really aggressive way if this is going to work. And it did. This was something that happened in June when the governor made the announcement, but then the community really started putting on pressure, saying, it's great to have an announcement. What we need is a plan. How is this actually going to get done? Now, we're certainly heading in the right direction, but how do we come up with steps, concrete steps that will actually get us from the 3,000 down to the 750? And so the governor did, in fact, announce on October 14th that we would have a task force. And magically, on October 14th, the task force had its first meeting. And someday we'll tell the story of how that happened. But somehow 64 people wound up in Troy, New York. They found their way to Troy, New York, which is a lovely town up just north of Albany. And that's where we had our first meeting. And from there until the final task force meeting, about 93 days later, we did what the governor asked us to do, which is to create this plan to implement his vision, which was actually kind of sort of Charles's vision, but don't say that. But this here in the middle is a picture of the task force. So this is the dozens of people that were on the task force, the dozens more experts and other people. I think I called them camp followers, but people that were really very important in the process as well, like heroes like Ginny Schubert, others who lent their voices and their talents to getting this work done. And the truly remarkable thing was at the end of the process, what we had were, as Jackie said, 30 recommendations and 7 getting to 0 recommendations that were adopted unanimously through a consensus process. And if you looked at who those people were around the table and you thought that they agreed on much of anything sometimes, it was truly a miracle. And Charles, in his role as the community co-chair, did a truly remarkable job. But it was really the cooperation of all the folks at the table that got us to the end point. So the blueprint is set up in a way where it really follows the first 3 points of the governor's recommendation. So getting everyone who is currently undiagnosed tested. So we have a law in New York State that all people between the ages of 13 and 64 should be offered a test, and wouldn't it be great if all the hospitals and doctors and others, clinics that are responsible for doing that actually did it? So there are a whole bunch of recommendations under that. The second one, this is our HIV Stops With Me campaign this year, Treatment Changes Everything. And the idea of getting folks to viral suppression, and we're taking really aggressive steps with that, working with the Medicaid folks. We're doing the first ever match between surveillance and Medicaid to find people who are in Medicaid, in managed care, and still not virally suppressed. And how can that be? But there are thousands of people like that, and we're going to do something specifically about that. And then PrEP, a lot of talk about it. Last year when we were first doing this, there were still serious questions like, is PrEP right? Is this going to turn everyone into raging sex maniacs or whatever? But I think the conversation has turned into a much more intelligent conversation of who's appropriate to be taking PrEP. But the idea that this can be a game changer, I don't think is that issue anymore. And then finally, over on the right-hand side, we had other ideas that didn't fit into the 3 points that the governor announced but are equally important. Like, for instance, around syringes and syringe access. When we talk about going from 15,000 down to 3,000, 7,500 of those 15,000 used to be injection drug users. Half the epidemic in New York State used to be injection drug users. New diagnoses, it's now down around 2 or 3%. And that didn't just happen out of anywhere. That was because of the syringe exchange programs, harm reduction done in New York State, the expanded syringe access program, all those things. And then other programs that, again, don't fit neatly into the 3 points but are equally important there. And the blueprint is filled with those. And then there were the getting to 0 recommendations, and which, again, the idea that we would get to 750 and declare an end of AIDS, it makes sense from a metrics position in terms of, we'll have our first ever decrease in prevalence, but we obviously want to drive this thing down as far as we possibly can, as soon as we possibly can. And the big and bold ideas like things that would eliminate or reduce stigma and discrimination, like passing gender, would be terrific. housing opportunities and nutrition support and all the great things that you guys do for all New Yorkers who are HIV infected and in low income was another one. And, some of these things have high price tags on them. But again, I think the task force rightly felt that it would be wrong not to show not only how to get to 750, but how to get this thing as close to zero as possible. So a lot of things were already happening. We didn't just talk about that, and that's an important thing because End of AIDS is a great slogan, but without the reality of what we can do concretely to end the epidemic, not so much. But we knew even in advance of, person taking my picture. So even in advance of this happening, the governor's announcement and the task force and the blueprint, there were things, really important things that are happening. So we stopped having written informed consent in New York for HIV testing. We were the next to the last state. We beat Nebraska to the punch in terms of elimination of written informed consent. But it was an important step for the community to embrace something that it hadn't previously really wanted to embrace because we are so protective of people's rights in New York around HIV confidentiality and knowing what's happening with you being tested. But that bottom one on the left-hand side, the 30% rent cap, I mean, if it hadn't have been for these conversations about end of AIDS, that wouldn't have happened. People had fought for that for decades, and yet it was really with the momentum built around the end of AIDS conversation that got put into Article 7, so it got done without having to go through the regular legislative process. It was put in through the governor's budget, and that cost $27 million between state and city, mostly the city, so hugely important. $27 million isn't a slogan. Ending written informed consent isn't a slogan. And even this year, we were able to do a couple of things in terms of written informed consent. It's still been maintained in prison settings. We got rid of that. Having people not have condoms taken away and used as evidence, that's another thing that the community had fought for. And again, these are all things that were represented in the blueprint and were done through the governor's budget process. And again, putting for the first time language about syringe exchange, specifically using those words, even though we've been doing syringe exchange for 23 years. This year is the first time ever that syringe exchange is mentioned explicitly in the penal code, so that police will please stop arresting people for carrying syringes that we want them to have so that they don't acquire HIV or transmit it to anyone else. So 6 changes in law, and then on top of that, $10 million in money, new money for us to help leverage and get this done. Now, some people, and I've had actually press people asking me, well, $10 million doesn't sound like a lot of money, but it isn't $10 million on top of zero. It's $10 million on top of $3 billion that New York already spends through Medicaid, through Ryan White, through state appropriations, through city appropriations already. So this is just a point of leverage. It's not the answer, but if we hadn't have already had that huge investment, we wouldn't have gotten to where we needed to be to start with. We wouldn't have gotten from the 15,000 down to the 3,000. That $2.5 billion that we spend in Medicaid on HIV services each and every year is at the same level as the entire national Ryan White Care program. So that shows you where New York's commitment is around HIV services. And the reason why we're leading the way is because we have made those investments, and not just for 1 year or 2 years, but for 30 years. And we are starting to get some national attention around this. The state of Washington on World AIDS Day last year announced that they were they mimicked our language and have announced their own plan to end AIDS, and by 2020, similar kind of thing, not really no cure, but doing what we can do with the tools that we have in hand right now. And I was just at a meeting, the National Alliance of State and Territorial AIDS Directors in Colorado announced that they too are joining us, so that's terrific for them too. And I'll personally go out to Colorado to meet with them about that. So this is a picture of the blueprint. Charles and Dan actually have copies there. We haven't been handing it out as a hard copy, because what we really want you to do is to look at it electronically if you can, because behind each and every one of those blueprint recommendations are committee recommendations that give you the meat of it. If you look at the blueprint recommendations, it's kind of in shorthand, and to really understand what the task force wanted you to get at, if you go to the blueprint and you click on, there are these codes, CR codes, committee recommendation codes, it'll give you the full committee conversation about why that particular blueprint recommendation was important. So this is a picture of the governor. They closed down a section of 13th Street out in front of the LGBT Center where so many great things have happened over the years. And that's where Charles King, this guy right over here, handed the governor the blueprint, and the governor made this statement: we must add AIDS to the list of diseases conquered by our society. And today we are saying that we can, we must, and we will end this epidemic. And a lot of other big and beautiful things were said that day. Charles certainly said quite a few, but you probably already have noticed, I don't have to point this out, but if you look at underneath the T and the second line, and the Y in York is my head. And perfectly framed, and I know that the governor's office did this intentionally to say thank you to me for my efforts, but I'm certain that that's the case. But that was such a great day to be standing there in front of hundreds of people and watching Charles and the governor talking about this not as a slogan but as a reality that we will end AIDS as an epidemic in New York by 2020. So thank you very much.
Dan Tietz. Oh, yeah. No.
If it's not cooperating, you might want to just start and I'll catch up here. So, I don't know what's going on. See if I go.
There's a mind of its own.
Yeah. There. Okay.
Great.
Okay, there we go.
Thank you.
Big hand for McLean.
Right. You know, I was thinking when you mentioned prevalence and how it's you know, the change in part because of the lower numbers, I thought, you know, there's also, you could do it Florida's way, which is to simply let them die. And then you'd have lower prevalence too. And I wish I was joking, which is, you know, the other choice is the one made by, frankly, far too many states, which is to do far too little. So when Dan talks about the investments here, it's not modest. That $2.3 billion in Medicaid, you know, many states haven't expanded Medicaid, and almost state for state have some of the worst epidemics in the country, and that's not accidental. So I do think it is to this governor's great credit and to the AIDS Institute's great credit that, you know, in 2011, when Governor Cuomo came to office and promptly set about redesigning Medicaid, you know, one of the ways in which he could have redesigned it was to simply cut, and instead chose to put together a task force then as well to figure out how to do this better, how to get better quality for less money. And so some of what we have today, including the Medicaid global cap, which we hope to get a piece of at some point, is possible. You know, to fund part of our work here is made possible because of that effort. So I think we're grateful for that. I'm going to, you know, my slides are really easy, and thankfully I didn't have to do them, but one of Dan's staff did. Because they are pulled right. How do you like that? I don't even work there, and I got them to do it. They're pulled right out of the blueprint. So these are essentially, and I'm not, you know, I may pop back around with these a little bit, but so this one's on page 29, just if you have it handy. And it's the first getting to zero recommendation. And so the housing piece, I don't have to, you know, persuade people who are coming to a supportive housing conference the importance of housing. But these are all completely interconnected. This one matters to me a lot because, well, it's the first under under the Getting to Zero recommendations, and it's also the one that would have the most impact where I work. So as you heard, I have HASA, and this would expand HASA, and we'll talk maybe a little bit later about to what degree, so we try to figure that out a little bit. But this, right now, 80% of the epidemic is in the 5 boroughs. HASA is only in the 5 boroughs. No other, right, I think no other social service district actually does anything quite similar. And you can name the ones where it would make sense, right? So Buffalo, Rochester, Syracuse, Albany, Westchester, Nassau, Suffolk. If you did those, you got 99% of the epidemic in New York State. And I think the reality is, so speaking of money, that it was noted that we pay a lot. So we pay a lot in the 30% rent cap. That split is 71% city tax levy, 29% state money. It's a capped appropriation. We hate the way the OTDA did the budgeting. We would do it differently to get in the higher SSDs, et cetera. So I think, there's some arguments to be made about that yet. But I think, 7129's a deal that no other county would take. And in fact, I would say that unless the state more or less fully pays, no other county is going to do it. And so we've got some challenges there, but I do think that there are ways to get to that place, not only by Charles getting arrested, but other ways to get to that place, because this matters immensely. You can't possibly expect that someone's going to get engaged in care and stay in care if they don't have a place to live, if they don't have food to eat, if they don't have a way to get to their appointments. It's just not going to happen. And we know that from the people who are in HASA now. We know that from the very difficult challenges that folks have with substance use and mental health and what have you. Unless they're engaged in some way and they have a stable place to live, it's just not going to happen. So, ensure access to stable housing. This appears elsewhere in the blueprint. So it's recommendation 16. This essentially says what I just said. The ones with regard to homeless youth, so obviously where the epidemic's growing most is among young MSMs, particularly Black and Latin MSMs under 30. We can be fuzzy, I think, about what equals youth. I think you stop being a twink by 30. So, there's that.
You don't qualify.
Yeah, I'm well beyond it. But this is, I think, terribly important that we think in a very holistic way. And I think I love how this particular recommendation was written. It was a bit of a fight, as I recall, and you should know, I don't know that you exactly said it, but these were all by consensus. So picture getting consensus from 65 people, some of whom are quite pushy. I mean, I'm a little I'm a little retiring, but others are very pushy, and there are times, I had to wait till 70 was hospitalized to get one of these. So then she was kind of like, unable to push back. But there was a lot of back and forth, and this was a comprehensive look. So this is indeed about housing and supportive services, but it was saying, look, these youth need a lot, all the way around. Mental health services, substance use services, they need employment assistance, you name it. And so it was really important to have this holistic view. And it really does start with housing, because again, people who don't have a place to live aren't going to engage in any of those other things I just mentioned. This goes at gender, which is on the agenda this week in Albany, but not only at gender. It certainly makes a big difference. A statewide protection for transgender New Yorkers is terribly important, but it's also broader than that. And this is really about cultural competency. Again, if we see this at HASA, we see this throughout HRA. If you don't treat people right, they're not coming to you for services. They're not going to get what they need. They're not going to ask what they need. They're not going to show up. And so it's a big challenge for us. And I also like that the AIDS Institute is moving quickly with regards to peer-led efforts and peer training, because I think that matters a lot in terms of cultural competency. The folks, get help and assistance and are guided by and see others just like them. The rent cap, as I noted a little bit earlier, I think has been central to this effort. We appreciate the mayor and the governor coming to an agreement on that in February of 14. HRA moved very quickly to get the rule approved by OTDA and to get it implemented. 8,500 New Yorkers have the rent cap. We're concerned, as I said, a little bit about how the budgeting is done. We pressed for a different way to do the budgeting that would have gotten more in. OTDA said no. We're going to come back at that, I think. But some of the folks with higher earned and unearned income are excluded because of that PA budgeting. And we're even contemplating at the moment, I'll just say that we may consider paying some of that with city tax levy just to get them in. But the rent cap was vitally important to a quality of life and making New York City just a bit more affordable for some of our poorest residents. So I'll let this move on to Charles.
So I want to, first of all, I'll stay seated. Fortunately for McLean, I don't have a PowerPoint for her to get the browser to click on. If I stay seated instead of getting behind a podium, it'll keep me from going into Baptist preacher mode. I want to thank everybody who's up here because this whole effort, it's been a good 2.5 years, and it has been a true community partnership, and community does include the AIDS Institute and other folk who hold bureaucratic titles but have been an integral part of this partnership and really believing in this and making it happen, not just doing what we often ascribe to bureaucrats, although I remember one task force meeting when Dan said, Dan O'Connell said, I've heard people complaining about this wording, that it looks very bureaucratic. He said, well, that's because I wrote it. So that is a part of it. But I do have to underscore what an amazing partnership this has been and continues to be as this evolves. So I want to real quickly run through some of the next steps and implementation before Kimberly gives me the sign. And I am going to assume that people are in this room not just because you're housing providers who are in the business, if you will, but because you're advocates and because you care about people. And so I'm not going to limit my conversation to next steps around housing, though I'll certainly try and address that. The first thing you need to know is that the coalition that has brought this together went to the mayor's office, met with Lillian Barrios Paoli the week after the governor endorsed the blueprint and asked that the New York City match the $10 million put up by New York State by putting up $10 million of its own. New York City represents 80% of the epidemic, and so we thought that was a fair deal. And not only is that a fair deal, but what that $20 million would do is it would leverage other resources that would allow us to begin implementation on just about every single initiative promoted in this blueprint. So next time you're at City Hall, whether it's members of City Council, whether members of the administration, urge them please to go ahead and appropriate that $10 million. Dan mentioned the getting to... This is going to be tough.
Every time, actually, you could just say Dan and then Saturday.
Actually, I think both of them mentioned getting to zero. I just want to tell you some of the legislative initiatives that are going to be really, really important. And I believe we got a lot of momentum, as Mr. O'Connell said, by framing this as ending the epidemic. But it's going to take a lot more push, and I don't anticipate that we'll see a whole lot happen in the next 7 legislative days that are still around this year. But I'm keeping in mind that the next legislature will not only face some of the controversies that they've had to deal with this year. There's still an investigation going on, but they'll also be coming up on election year and have something that they have a need to deliver to their their constituents. So I'm hoping we can actually get all of these through, if not this year, then next year, because they are critical. One is comprehensive condom decriminalization across the state. New York is one of, I believe, only 8 states in the nation that criminalizes the possession of condoms without a prescription. We made an amazing step forward getting needles, syringes in the penal code, but we need to go all the way forward and completely decriminalize, I'm sorry, syringes.
Syringes.
Yeah.
I don't know where I got condom. All right. So syringe decriminalization, I wrote down condom. Actually, no, so I'm sorry. I do know where that came from. We actually made a huge advance this year, and I don't think you mentioned it in your slide, or did?
Yeah, it was there.
Yeah, okay. And that was decriminalizing possession of condoms for purposes of misdemeanor charges. We need to completely decriminalize possession of syringes as well. And along with that, the governor did put forward this year significant reforms of the ESAP program, which allows pharmacies to sell syringes without a prescription to people who are using drugs, that will reduce the cap on number of syringes, would also allow pharmacies to advertise. We've proposed that we enhance that even more by allowing pharmacies to get grants to train pharmacy assistants to do drug treatment referrals. And, you know, if you've read about the rising heroin epidemic around the state, particularly in more suburban and rural areas where needle exchange might not be the appropriate intervention, if we want to keep the low transmission rates among people who inject drugs, we really need to expand the ESAP program. In addition to that, Mr. Tietz mentioned gender, absolutely essential to our agenda, as well as the Healthy Teens Act, which would not mandate comprehensive sex education statewide in the schools, something that's probably impossible to mandate in New York State under our current climate, but would provide grant money to schools that were willing to actually take the risk of providing comprehensive sex education. And with that, minors' right to consent. In New York State, minors have a right statutorily to get tested for HIV, but believe it or not, in New York State, they have no statutory right, if they test positive, to get treatment without their parental consent, and they do not have a statutory right to get prophylaxis for HIV, or for that matter, prophylaxis for HPV, and that's a really, really important step forward, giving minors the right over their own bodies, their own health. So I think those are really critical issues. Another issue is expanded Medicaid/insurance access, and we had looked at expansion, and it's in the recommendations of the Family Planning Benefit Program. That probably requires federal action, but New York State did just pass legislation that put in place the basic health care program, which we think is going to make health insurance available to every New Yorker who currently does not have legal access to insurance and could provide the preventive health care. And then there is the single point of access proposal. If you were to implement this proposal statewide, it would cost somewhere between $600 and $720 million over the course of the next 5 years, getting us to 2020. But guess what you would get in exchange for that investment? You would get $1.08 billion in Medicaid savings for the improved health outcomes that would accrue to the 10,000 to 12,000 people around New York State who would be housed as a consequence of initiating that program. You would also save $520 million in averted new infections. And on top of that, New York would save, and this would mostly accrue to the localities, $120 to $180 million in reduced use of shelters. So you add all of that up, that's a lot of payback on an investment of $600 to $720 million. That said, I don't think that we're going to see that in the governor's next budget. But I think there's many other ways to skin the cat. And I want to take a few minutes of your time to talk about what that might look like. First of all, imagine if just in HIV/AIDS supportive housing, we did what California is proposing and took all of the services that we're providing to people associated with that housing that keep them in their health care, and we're able to transfer those costs to Medicaid. That would probably provide us somewhere between $20 and $30 million a year in savings that we could then invest in housing. Now, we've looked at it. It's not, I'm giving a lower estimate than I used to give because we think that those dollars actually carry some costs that Medicaid probably wouldn't pick up. But that's a healthy chunk of money going towards my $100 to $120 million a year, right? The second is New York, New York. So up until now, the preceding New York, New Yorks, which have been restricted to the city only, somewhere between 20 and 25% of those units each year has gone to people with HIV. We think that there's probably somewhere between 3,000 and 4,000 people around the state who are living with HIV who need supportive housing. Well, you take that 20 to 25%, take that out of the 5,000 units that was proposed in this or passed in this last, we don't get even halfway there. We need a real New York, New York, and Housing Works, as part of the New York, New York coalition, actually proposed that instead of having a sit-down lunch in the ballroom today, that we all march over to the governor's office en masse and demand that we get a real New York, New York legislation forward that would do something more on the order of 20,000 supportive housing units statewide, because that's exactly what we need. The coalition decided not to use lunch hour today. They thought you all might be hungry. But there is actually going to be a demonstration in front of the governor's office at 11 a.m. on June 12th. So be there or be square. It's not just for people with HIV. It's for all people who need supportive housing. And that's a big part of the solution. And then the last part of the solution is something on the order of $40 million a year to provide statewide rental subsidies for people with HIV who are low income and can't afford rent on their own. That's a big chunk of money, but when you think that this last year we appropriated in Medicaid savings $250 million over the next 2 years for housing needs, and that's a great investment. If we could get CMS to match that investment, setting aside $40 million a year for a statewide rental assistance program for people with HIV and AIDS doesn't sound like that much. There's another way to skin the cat that we're discussing with Jason Helgerson, the Medicaid director, and that is in the context of the global cap, and Mr. Tietz referred to this, that we set a separate global cap just for HIV. If we can accrue the savings that we think we can accrue, and they net to about $4 billion, if by implementing this plan, if we think we can accrue those kind of savings, then if we put a global cap on HIV/AIDS spending in Medicaid, that will throw off enough money to fully fund this plan and then some. And when you think about it, by the time we get to 2020, by the time we get to the point where we're actually seeing a net reduction of people living with HIV in the state, that money starts coming back big time and setting a pattern for how we can address other disparities in health. There's a couple of other things that are really, really important to this. One is the rollout of the Delivery System Reform Incentive Payment Program, DSRIP, which you probably have heard about even if you're not a part of that process. And there's two very important parts of DSRIP that are important to HIV. One has to do with population health, and I'm very proud to say that almost every performing provider system in New York City selected HIV as a project to implement in population health, and we'll be looking at how that rolls out and how that impacts the epidemic in New York. Unfortunately, PPSs outside of the city largely did not do that, but there is another project around people who are either uninsured or are not using their insurance except for emergency rooms. It was called Project 11. It's now called 2DI, which I don't expect you to remember, or Dan says to die. That's O'Connell. That we think can be leveraged, and we're talking with the folk who are running DSRIP overall about a learning collaborative that would require the PPSs who receive that money to incorporate HIV prevention and viral suppression into that project. So I think there's many elements that can come together to really make this happen and bring the resources that we need. Just a couple of other things that I want to add before Kimberly flags me. I've been avoiding looking in her direction.
You for a while.
Oh, she has? I didn't see it. First of all, what is the role of housing providers in all of this, whether you're in HIV or not? One, if you're doing supportive housing, you're serving people at risk, even if you're not serving people with HIV. And I think you definitely have a role in three ways. One, if people are HIV positive, ensuring viral suppression. Two, if people are HIV negative or unaware of their status, ensuring routine HIV testing. And if people are engaging in potentially risk behaviors, introducing them to pre-exposure prophylaxis and non-occupational post-exposure prophylaxis. The other thing that I wanted to mention is that there is going to be a statewide summit here in New York on rolling out implementation of the blueprint on July 8th. So feel free to contact any of us if you want more information about that. And we will be conducting after that regional summits, including summits in every borough in New York City, and so please make yourself a part of that. And then just to close and sort of give some context to this, I think that we're talking about a lot of programs, a lot of interventions, a lot of legislation, but what we're really talking about is people's lives. And when you look at the two populations where we have not seen a significant impact in reducing HIV infection, as both of these gentlemen alluded, it's young men who have sex with men, primarily African American and Latino men, and young transgender people, again, principally African American and Latino. And there's a lot of discussion about what we need to do to reach those populations. And what I said in my remarks to the governor, I think really is true, and that is that in order to reach that population, we need to show that we care enough about them, not only to protect them from discrimination, but also to offer hope for a meaningful future. And I still believe that's how we end the epidemic for those who are not yet infected. And for people who are living with the virus, I traveled around the state last fall in listening sessions, both formal and informal. And uniformly, when you ask somebody living with HIV what ending AIDS meant, they said, yes, viral suppression and good health, but also stable housing, food to eat, transportation, and meaningful vocational opportunity. And when you think about that, isn't that what every single one of us wants? And that's how we'll end the epidemic. Thanks.
Thank you, Charles, and both Dans. Charles actually answered at least 3 of the questions that I was going to kick us off with, so we're not going to do that. I'm going to turn it out over to you, or does anyone have any questions in the audience? Really? Thank you.
I used to work with ag housing before, years ago I started. And then I transitioned to work with supportive housing. And for many years, I always felt that there was this kind of 2 different worlds. What the city was doing in terms of developing housing for people with AIDS through HACCP, and then I would go to meetings there and talk about this. And then you will go to supportive housing, like this type of events, and it was, we talk about like people with disabilities, people with psychiatric disabilities, and also people with special needs. But there was no connection there. I'm not sure if I'm wrong with that, but I always felt that there was this kind of 2 different worlds happening in terms of housing. And I mean, it's good to have this panel, and this is the 15 Shipping Council?
Yes. Yep.
I don't know if we have previous, discussions about housing related to people with AIDS within supportive housing, maybe not too many. But I think there's something needs to happen there in terms of like, how do we integrate those two? It's already happening. You mentioned the New York 1 and 2, and now we're fighting for New York 4, so maybe that's what it needs to be.
So first of all, I do have to say that I think for many years, Shinny has had at least one session related to HIV/AIDS at its conferences. And I think many AIDS housing providers are proud members of the organization. But you do speak to a core truth, and the core truth has to do with the fact that supportive housing has, for as long as I've been in New York, operated in disease-specific silos. And I think one of the transformations that we're seeing around Medicaid redesign, around DSRIP, I think, and then pay for performance, I think will bear this out, is that, and I think it's embedded in Health Home, is that we need to move beyond the idea that you are defined by the particular chronic condition that you have. God help the person who's got 3 to 5 different chronic conditions and has to choose which one qualifies him or her for stable housing. So I do think that's the essential point, and I do think we've begun to cross a very important bridge in that regard.
Yeah, I mean, New York 3, we were confined, by the categories. So as you know, HRA manages this a bit, except for the OMH piece of it. I think the thinking about this has very much changed, and some of the law around this has changed as well. And in the mayor's request, I think it's more than a request, it's near to a demand with regards to New York 4, whatever we're going to call it, was 12,000 units of supportive housing in the city alone, and that wasn't in those weren't in tidy boxes. So I think there's a change in thinking about it.
And in fact, I was just in a session where the governor's office explicitly announced that they are not going to accept any categorical caps on who gets what units, whatever the size of it is, that it's available for people who need supportive housing.
Go ahead.
I was just curious, you mentioned that there's a need from the city for $10 million. I was wondering, was there a timeline that you needed that by, and was there any anticipation on when that decision would be coming through, if at all?
Sure. We would like to see $10 million in this year's budget. And just to give you some of the specifics, Dan mentioned that there's a group of people who should benefit from the 30% rent cap, but the way the regs were written, have incomes just slightly too high. And so one of our asks is for a pot of money to actually make those people eligible so that they can stay housed. Almost all of the rest of the money is funding. It would allow DOH-MH to fund a number of new initiatives that are recommended within the plan that could best, one of the things that has happened out of this whole process is an amazing partnership between the State Department of Health and the City Department of Health and Mental Hygiene, and it would allow the City Department of Health and Mental Hygiene to carry its weight in launching some of the critical new initiatives, particularly initiatives around PrEP. One of the exciting ideas is using STD, the city-run STD treatment programs as opportunities to introduce people to the idea of PrEP and get them into long-term care, and there's no funding in the current budget to do that. So that's what it's all about, is those types of new initiatives that would really supplement and take us to the next level here in the city.
What's the deadline for that budget?
Well, that budget, the city budget has to be, I think the requirement is that it be in place by July 1. And so this did not end up in the mayor's executive budget, no fault to the mayor's office. They wanted to see the blueprint. The blueprint came out on the 29th. We met with Lilium on the 4th, and the budget was coming out on the 7th. So I think there's a sympathetic ear in the mayor's office, but the more they hear from you and the more the city council hears from you, this mayor has a big agenda, wants to get a lot done, and so making this a priority would be important.
So it's both a question and a comment, and it's first is that supportive housing is a wonderful thing, and we've seen folks achieve wonderful things through it. But there are challenges that we are seeing today, and that is as we provide scattered-site housing, but we also build housing. So in the scattered-site model, we're seeing more and more landlords in today's environment lease units because nonprofit organizations are not subject to rent stabilization, so we're losing units there. We're also seeing rents that are above the fair market rents that are in line white and HOPL contracts. We're also facing some landlords who we've had long relationships with who have simply, we've carried them through the dark times, but now that things are better and they can get more money in the private market, pricing us out. And so that's a particular challenge. So when you look at scattered-site, sometimes I wonder whether or not how viable scattered-site is as a model. I mean, it certainly has helped people. It's helped achieve a lot of things. We've had folks in scattered-site housing for 20 years, and they've been able to achieve great things. But it makes me wonder about that. And then also, it's like when you look at supportive housing, when you build it, it takes time and to build it. It takes 5 years maybe to build a beautiful building, which will put many, many units on as available for folks. But it's a challenge. And I think that this is an effort. I mean, it's like when people say we're going to get more units of housing for scattered site or other kinds of methods, I sometimes say, but where are we going to get them? That's as a provider's challenge right now. It's like we're having a tough time maintaining our existing contracts, never mind finding a landlord. And in addition to that, we are competing against each other, right? And so we all know. So we have a LINK program helping folks with coming out of shelters, and they're offering incentives. And I've even heard today that people even with the financial incentives, that the LINK program is having some challenges. So it's a comment, but it's also a question if you guys have some answers and insights, because I do think this is a huge challenge for providers to achieve the goals of getting people housed.
Yeah, it's very difficult. The scatter site model, I think I agree with you, it's been very useful. We are desperate to hold on to the units. I would say that we recognize the increasing costs everywhere. We've tried to match the rental assistance in HASA with some of the terms that are in LINK. So both LINK and the new city FEPS program are paying at Section 8 levels. So in a 1 to 2 person household, that's $12.15 a month. In a 3 to 4 person household, that's $15.15 a month. The good news, I guess, with regard to HASA is we have case-by-case financial analysis. So we have a guideline that's a little less than $12.15, but we have room to be flexible, and that's made a big difference. I'll also note that one of our principal goals with regard to homelessness generally in the city is please let's just keep them in their apartments. So LINK is for people coming out of shelter. City FEPS is an avoidance of shelter. We've matched, for example, the broker's fee that we're paying in LINK with the broker's fee in HASA, so as not to disadvantage one program versus the other, since they're essentially looking for apartments in the same market. And then I think we're also doing a great deal more with regard to legal services. So all of the legal services contracts in the city were consolidated at HRA and are managed from there, and then we've doubled the money. I mean, there's a lot more money in it than there had been in the previous year. So we're giving folks legal assistance to fight back to keep their housing. We're taking, the law department, among others, are looking very carefully at source of income discrimination, which is illegal in New York City, and we want people to tell us when that's what they're hearing. Some brokers and landlords are more artful about that than others. I'd like to hear about both the artful and inartful. So we're doing whatever we can, but I'm not going to suggest that it's easy. I mean, the mayor's committed another $100 million to all of these programs, to all of these efforts, which is a big chunk of change in this market. And I think you look at the mayor's affordable housing plan. Yes, it's a 10-year plan. Yes, it takes time to do that. But in the meantime, our goal is to not only keep New Yorkers in the apartments they have now, or assist them to get others. Paying one-shot deals like nobody's business at the moment, and as well as to come up with these new programs. I mean, it's important to note that Advantage ended in 2011, and nothing came after it until last fall. And in the meantime, the economy has improved, at least for some, and it's pushed us out of a lot of out of a lot of neighborhoods, and so we've got some catch up.
And if I might respond to you also, last week we had our annual HIV advocacy day at City Hall with the City Council, and that the $300 million was an emergency funding specifically for the nonprofits who are not being covered by the rents that are going up. So that was one of our 3 asks. So so let your City Council person know that the nonprofits are stuck, because the landlords can raise whatever you, of course, then you can't have the money to do what you do. So we're explain to them how this is very important. I live in support of houses. I just want to direct me, the fact you direct me, but the point is, we are aware that we're letting our city council people know. Let your city council people know. They're receptive, but if they don't know about it, they won't know.
I'm actually also a person that was in the HIV/AIDS field and is now doing housing. So I think your point is very interesting that you brought up in terms of the different silos and how there's sometimes not a whole lot of joining of these things together. But in Charles King's point about what individuals need in terms of housing, health, and so on, I wanted to add also identification and documentation, which I think the mayor here has done a really great thing in terms of the NYC ID program. And I think that that's really wonderful in helping individuals be able to access services and entitlements when they may not otherwise have the documentation to even get their foot in the door. That being said, there are 645 1,000 individuals in New York City that are undocumented. And they're kept out of services, they're kept out of entitlements and housing through things like the Medicaid redesign team and other barriers, which does not allow individuals who may be very beneficial to the city in terms of a lot of the work that they do, and many times even paying taxes, but are not able to benefit from the entitlements, are not able to benefit from housing. And so I think that while a lot of the ending the epidemic points sound excellent, there's 645,000 New Yorkers that are not able to benefit from it. And unfortunately, I think that is going to always keep the number from zero, particularly given that sometimes they're the most vulnerable people. They do fall into a lot of the categories in terms of being LGBT, being Latino, and coming from a lot of different places, which already put them at risk in terms of a lot of the New York State legislation for the New York State DREAM Act, for example, that also makes it very difficult. There is some, I know there are some benefits out there, but it's really not enough. So I would like to hear, in terms of ending the epidemic, where do undocumented people fit?
Yeah, so I'll just start. I mean, obviously, it's a huge problem. It's one of the reasons why we desperately need to maintain the Ryan-White Care Act as part of the solution. It's not necessarily the solution for housing, but in terms of medications and care, we desperately need to have those funds. It's hundreds of millions of dollars coming to New York State, and a large segment of the folks who are served under that are called categorically ineligible for other services, and of course those are new immigrants, folks without paperwork necessarily. So that's part of the answer. It's not sufficient, obviously, to get to zero, but we have other state resources that don't have the requirements on it that around documentation, but it's clearly not enough. But we do have funds there. It's not like there isn't anything that's going towards those folks, but clearly not enough.
So that's why it was very important to mention the basic health program. First of all, just so level setting, anybody who's HIV positive in New York State does have access to particularly HIV, but also other healthcare services through our ADAP program, which has a considerable amount of federal dollars in it that Dan is making reference to, but New York State has been more generous by far than any other state in fully supplementing the ADAP program. So if you're HIV positive, you do have access to largely comprehensive health care. I won't say it offers every single thing, but largely comprehensive health care. But for many years, we have had a state-only Medicaid program, often accessed through Health and Hospitals Corporation here in the city, but available to some populations of new immigrants in other parts of the state as well. And the basic program is actually intended to substitute federal, a fully federal participating program. The regulations have not yet come out on what the basic program is going to look like, but our hope is that it is a very expansive program. Again, it is more limited than most insurance programs will be, but is supposed to provide for free all preventive health care services, and we would hope that that would include pre-exposure prophylaxis and post-exposure prophylaxis as well. So I think that's an important step, and frankly, if we could get CMS to recognize the need for housing as a healthcare intervention for people with chronic disease, then that's another step that we could leverage that I think would be incredibly important, as well as beginning to look at why here in New York State we are excluding people who don't have papers from certain entitlements that are in many cases state-only entitlements that we could probably be generous enough to expand to include.
HRA does the back office, so does the investigations, takes the applications, processes the applications for ID-NYC, and issues the cards. When we did the math on this, just a little, side note on ID-NYC, when we did the math on this, we took, sort of proportionally what San Francisco had done, given that they rolled this out and they had quite a bit of demand, and then we took their number and proportionally multiplied it by 3 and figured that's how many we would be issuing in the first, 10 weeks. We then, when we actually did it, we actually issued 10 times as many cards as we thought would be our high estimate. So I think in the first 10 weeks, we issued 200,000 ID-NYC cards, which is pretty amazing. And I was loaning staff to keep that rolling, which was tough. I just asked one of my staff about this, since it's not my expertise, because I thought that some undocumented migrants can actually get HASA rental assistance, and they can if they're cleared for PRU-call status. So if you have that, then you can get the rental assistance.
One more question, anyone? Okay, great. I want to thank all of you. This has been incredibly informative. Thank you all for coming.